Welcome to the Tri-Weekly Critical Care Journal Club. And today we have three hot topics that we're going to discuss. One of them is presented by Professor Diva, which Professor, that's not the PowerPoint, right? Is it the PowerPoint? Yeah. Professor Diva is one of our interns, esteemed interns. She is going to anesthesia next year, and that's why she's good.
Good, yes, I agree.
Huh? And so she showed up, Dr. Nick, she showed up yesterday for the first day in her rotation. And then I told her, you're assigned to do the journal club tomorrow. She's done it. So that's by itself is amazing. So you can stand over there, take this with you, you can move the slides with it. Thank you very much. So she's going to present to us a very hot topic here, which is rhythm control versus rate control. That's intersection of medicine and history.
All right, well, hi everyone. Like Cal just introduced myself, I'm Divya. I'm one of the transitional year residents going into anesthesia, and I was assigned this paper yesterday, but today we will be talking about rhythm control versus rate control in patients with atrial fibrillation and heart failure with preserved ejection fractions, and sort of just some highlights of the current guidelines. So just a little bit of background. HFpEF, or heart failure with preserved ejection fraction, accounts for about half of all heart failure visits and hospital admissions. Afib, which is very common, is the most common sustained arrhythmia in patients with heart failure. It occurs in approximately 1/3 of patients. In patients with HFpEF, the prevalence is anywhere from 15% to 41%, sort of depending on which study that you're looking at.
I'll move this for you.
Oh, thank you.
I think I can minimize it.
Well, I don't want to remove it completely. So.
And so, despite the fact that, so Afib is common in patients with heart failure associated with higher mortality, readmissions, and readmissions, the data shows worse outcomes in HFpEF complicated by Afib. There are no current specific medical therapies that have definitively shown to improve outcomes for patients with HFpEF and Afib. So just for my own review, I did a little bit of research into kind of how these two conditions can sort of coexist and how they kind of play off of each other. So sometimes patients may first have Afib, and that tachycardia, the loss of the atrial kick, and irregularity of the rhythm can actually lead to HFpEF over time. In other cases, a patient could have HFpEF because they do have a lot of shared risk factors such as hypertension, aging, obesity, diabetes, and that structural and electrical remodeling of the heart can then lead to Afib. So the current guidelines for Afib and HFpEF management focus on the prevention of thromboembolisms or clots and symptom control to correct underlying causes of Afib and heart failure and to optimize heart failure management. The guidelines then sort of differentiate people, like I was just talking about, who develop heart failure as a result of Afib, and others who have heart failure and go on to develop Afib. So patients with newly diagnosed heart failure in the presence of Afib with RVR, so someone who already has Afib, they're recommended to undergo rhythm control since the kind of rate-related cardiomyopathy is a reversible cause of the heart failure itself. But aside from that, there's no other specific recommendation for rate versus rhythm control in the guidelines. And the guidelines recommend rhythm control only in patients who remain symptomatic despite rate control treatment already being given. So this study kind of looked at this AHA's, going with the guidelines, heart failure registry, and used some CMS claims data for Medicare enrolled patients to look at both patients who have this documented history of Afib along with, along with their claims data to sort of ascertain long-term outcomes following discharge for the patients. And so in order to do that, they looked at these specific denominator and inpatient research identifiable files that had like patient data in it. And overall, they had almost 16,000 patients as part of this registry, and it was from 2008 to 2014, so it was a good amount of years worth of data. And it was a voluntary registry, so hospitals had to sort of sign up to be a part of it. They define rate control as any combination of a beta blocker, a calcium channel blocker, or digoxin, and so a patient on any of these medications. And they define rhythm control as a history of or current hospitalization for an ablation or pulmonary vein isolation, or a treatment with amiodarone, sotalol, or any other kind of antiarrhythmic, or someone who is inpatient for an elective cardioversion. And they defined HFpEF as someone who had a documented EF of greater than or equal to 50%. So looking at this sample of almost 16,000 patients, fewer than 2,000 were treated with rhythm control, and the majority of 13,800 were treated with rate control. And the next slide, sorry, it's a little small, but they're just showing kind of like the baseline patient characteristics, including age, sex, smoking, sort of other comorbidities such as hypertension, hyperlipidemia, renal insufficiency, things like that. And just sort of comparing the two, they are mostly similar between the rhythm and the rate control groups.
So all of them are the same? I mean, there is no significant difference between any of those
So
things?
they didn't actually test for significance, like there's no, but when I was looking at it, I did see that for atrial flutter, I did see a bit of a difference. So the rhythm group has like 6% and rate had 3.5%, and I know it's like a harder to control rhythm in general. But there were some minor differences, but they didn't really test for significance. So, sorry, I'm gonna have to move this again so you all can see me over here. Oh, that's better. So this was kind of the main results from the paper. They were looking at outcomes for patients who were being treated with rate control versus rhythm control after a 30-day period as well as a 1-year period. And what they did actually find surprisingly was that for patients in the rhythm control group, they were significantly less likely to have sort of like the outcomes of all-cause death, readmission, all readmissions, stroke readmissions, and heart failure readmissions. So, and it's interesting that it's not necessarily shown to be significant at the 30-day time point, but after 1 year, you are able to see these differences.
Can I ask you, anticoagulation was continued on both groups?
Yes,
Or?
it was just the difference with the rate versus rhythm control. So this sort of, they looked at hazard ratios and looking at both the unadjusted and adjusted outcomes. And with the adjusted outcomes, they adjusted for like patient comorbidities. And there they found that the hazard ratio showing all-cause death was significantly lower in patients who were being controlled, who were being rhythm controlled. They also sort of kind of really wanted to drill down this point, so they did a Kaplan-Meier kind of like a survival curve, and even there you can see throughout this time period, patients who were being rhythm controlled did have a higher survival probability.
Lila, can you go the one before, the slide
Sure.
before? So looking at the top graph, it looks like, you know, none of them touched the baseline. Which one touched the heart failure admission? Touched that a little bit, right?
Yeah, it touches it a little bit.
Yeah.
But
And the p-value is exactly 0.05.
Yeah, exactly.
But
The rest are
that's the
all
unadjusted outcome.
unadjusted though.
If they're adjusted for the risk factors, I mean,
Mhm.
for the age,
Yeah.
whatever,
Yeah.
then that's actually the major thing.
Right, so it's really only, once you adjust for all of those factors, it's really only all-cause death that shows that significant difference. So just a little review of the treatments that they covered in the paper. So the looking at kind of medications specifically for rhythm control, there are only 2 antiarrhythmics not specifically contraindicated in heart failure, and those are amiodarone and dofetilide, which were used pretty significantly. About 2/3 of the patients did get amiodarone and 2% got the dofetilide. Other rhythm control medications such as the 1C agents, propafenone, flecainide, dronedarone, are actually considered harmful in patients with HFrEF, so reduced ejection fraction, but these warnings have been extended to patients with HFpEF as well. But there's limited sort of studies that have shown that that actually is a legitimate extension of the warning. And they actually found in this study that dronedarone specifically and other 1C agents were used in about a little over 10% of the rhythm control group. So despite sort of that this warning, it's still being used. In terms of ablative therapies, it has shown to be safe, but hasn't been specifically studied in this, subset of patients with both Afib and HFpEF. In general, in terms of freedom from Afib long term, catheter ablation of Afib has been shown to be superior to amiodarone. So, this paper obviously has a significant number of limitations. First of all, it's a retrospective observational study versus, a randomized control trial that we can really draw definitive clinical guidelines from. They obviously adjusted for all the clinically relevant covariates such as hypertension, hyperlipidemia, all those other kinds of comorbidities, but there are definitely some measured and unmeasured variables they weren't able to include, such as like the specific subtype of cardiomyopathy or other sort of rarer comorbidities. Again, this is sort of a static picture in time of, what the patient was being treated for their Afib in that moment. Afib treatment is pretty dynamic. Patients can be changed from rhythm to rate control or could be changed on different types of medications within those 2 groups. And again, the strictness of rate control wasn't available for adjustment. They didn't have that information, so we all have heard that stricter rate control can actually lead to worse outcomes. The other thing was they weren't able to analyze patients with regard to the duration of their Afib prior to being enrolled in this, or if it was permanent versus paroxysmal. And again, in the rate control group, they defined it as anyone who was on a beta blocker or calcium channel blocker, but the patient could have been on those medications for their hypertension or for angina or for some other use. And again, in the rhythm control, the antiarrhythmics, even though they were likely used for Afib, they could have been used for treatment of other ventricular arrhythmias. And again, the time and initiation and duration of the amiodarone therapy was not available.
So the fact that this is a prospective trial?
Retrospective.
Okay,
Yeah.
so they're looking at
Yeah,
everybody with the,
exactly.
So
So
they
it
don't know
was-
where amiodarone was started.
Exactly. They looked at like 6 years of data, but that was from 2008 to 2014, but this was published in 2019. So yeah, just a little recap. What's new about this paper was just showing that Afib is common in patients with heart failure, is associated with higher mortality, readmissions, and heart failure readmissions specifically. And patients who are 65 and older, because that was the sample, it was a Medicare sample, with heart failure, with preserved ejection fraction, and Afib treated with rhythm control were found to have this association of lower 1-year mortality compared with treatment with rate control. So that's about it.
I love it.
Thank you.
Great.
And now we have
The question, yeah. Go for the question.
All right, so the question is, which antiarrhythmic agents are not specifically contraindicated in heart failure? So is it A, amiodarone and flecainide, B, amiodarone and dofetilide, C, dofetilide and sotalol, or D, flecainide and propafenone?
This is the question. A?
So in the paper it says B, amiodarone dofetilide. But I think, but the sotal is also among them, which didn't say in the paper. I don't know why they say amiodarone dofetilide.
Yeah.
But you can use sotal for the heart failure reduced ejection. You can use sotal too.
Okay.
And flecainide and propafenone is not, I mean, in the reduced heart failure, the reduced EF, you should not use flecainide in class 1C agents. In the heart failure with preserved EF, I'm not sure how strong is the contraindication. It says in the paper it's been used. We've been used it sometimes, but I don't think there's a strong contraindication for class 1C like propafenone or flecainide. But definitely amiodarone and dofetilide is a choice for the heart failure reduced EF. Sotalol is also, you can use it. I'm not sure why they didn't mention it in the paper.
And when you say heart failure, you mean
Heart failure reduced
EF.
Yes.
The
With
other
heart
one is
failure,
just extrapolation.
sorry?
The preserved EF.
The
is
preserved
extrapolation.
EF, it's not a clear guideline not to use it. Usually, if there are the thick LV wall, or I mean, if there is anything structural heart disease, you prefer not to use the flecainide and the class 1C.
Yeah.
You prefer not to use them. And the reason is because if there is any scarring, they can use the risk of VTAP.
So what would be the drug of choice among amiodarone and dofetilide if there is no other issues? What would you go for?
What I would use, there is no nothing in the guidelines between the two, except for if there is the LV thickness is more than 1.4 or 1.5. I have to refresh my memory. You have to use amiodarone. You cannot use dofetilide. But if the QTC is okay and patient is relatively okay, you can use dofetilide. I would go with dofetilide over amiodarone because of the less long-term side effect. Amiodarone, I mean, after a couple of years, you always see something. Thyroid toxicity or something with the liver, and the worst is the pulmonary fibrosis.
So, I mean, this study, I mean, one of the, from my point of view, or our point of view in the ICU, is rate control versus rhythm control. It's been, and I didn't know, I mean, I want to confirm that you said something that's very interesting to me, that rate control and rhythm control hasn't been shown to make a difference, right? In outpatient or inpatient?
I was just talking about in general, like not in patients with heart failure.
So in general, rate control versus rhythm control don't make a difference, and of course there's a risk of developing stroke from rhythm control agents.
So that paper was a long-term, so it's outpatient setting. So
I'm talking like as a background, right?
Oh, as a
This paper comes in and kind of shake that principle a little bit, because to me, as just a simple-minded person, it looks to me like rhythm control is better, as far as heart failure, But the study shows no difference, so we didn't for years, we did not really go for the rhythm control. Will that change the practice?
So, I mean, that's a long thing. So
I know, you can give me the short answer.
So the short answer is that the concept is coming from the Afib trial. The first trial, which was like 10, 15 years ago, or even more, that they compared the rhythm control versus rate control. They said there is no difference. So there is a rhythm control versus rate control. There is no difference. You have to go, all of this trial, you have to go to the detail of it. What are the populations? Can you apply that study to your population?
Yeah.
The Afib trial, which is a cornerstone of what you just said, the rhythm control, rate control, the average age is more than 70.
Oh.
Okay. So are you able to apply the result of the paper, which the average age is more than 70, to the people who are like 50. If the patients would come with a 50 years old, we would say, oh yeah, we're going to do rate control and go over. I mean, you gotta be fine. So I think the answer is no, but the thing is we don't know. Then they're looked at there are a lot of trials that look at the rate control versus the rate control. The impression that I'm getting for now, it's in the guidelines, seems that if you try to do it with the antiarrhythmic, it's helpful. However, because the antiarrhythmic has the side effect, that would nullify the benefit because of the risk of antiarrhythmic. So it's you can see in the guidelines if ablation, especially in the earlier stage, is helpful for the rhythm control, especially for the younger patient. That's what's currently is being implied in the guideline.
Which I think is very interesting what you said. We were talking about it in evidence-based disasters yesterday. It's individualized. So if you take 50 years old, 60 years old, it's like totally different animals than if I say an 80-year-old and I'm just insisting on rhythm control and that's bad. That's like
so
that's,
all of this deviling is in the detail. You have to know what is the population, what they looked at, and can you apply the result of that paper to your patients. That's why. So it's especially important if you want to go with the Afib trial, was the most important one. You have to know that the average age is like 75.
Do you know that the average age here is 83?
Yeah.
There's a couple of other things. This data is not really that strong. If you look at the confidence interval, it was all the way up to 0.98. And then this was obviously, as already mentioned, it's a retrospective trial. So the data in this trial is not super convincing.
The other thing that you have to know about the Afib, I think the Afib is not one patient, not one disease. There are different kind of disease all labeled. I mean, there are Afib, but there is an Afib in a younger 50-year-old which going paroxysmal Afib. There is another with a normal LA size. There is another Afib with an 85-year-old with a very dilated left atrium. It's a different kind of Afib. Older guy, it's all left atrium is fibrotic. The younger guy, LA is LA size is normal, and it's all because of the electrical chaos in the pulmonary vein. So it's a different mechanism, different subset of disease.
That's very important. But can you just repeat that again? For the younger population, the Afib is different than the older population when it comes to.
I think it's not even one disease. We label it as the Afib.
Okay.
It is Afib. You can see the Afib, but it is you can have an approach in a different, but as a different disease even, because the mechanism is different, and the treatment is different. The outcome is different. So one of the things that you have to look for is you look for the patients, left atrial size, their risk factor, to get an idea, is it mostly because of left atrial fibrosis and enlargement and remodeling, or is because of the pulmonary vein, they call chaotic, that's a good word for it.
Chaotic focus.
Chaotic focus, yes, that's something.
Wow.
There is other thing, parasympathetic induced Afib that people get it as a sleep. But that again, that's a different kind of Afib. So these are Afib, but it's a different kind of disease.
Can I add one more type of Afib?
Yeah.
Everyone's got that. ICU Afib.
Yes, that's true. That's
totally
true.
different animal.
That's completely true. It's like post-op Afib.
Yeah.
People are going to the cardiac surgery, they get Afib, but it's a completely different thing than the people who has paroxysmal Afib.
Yeah.
It's the same thing.
Wow, this is better discussion than what I thought. Holy moly. That's way higher than my pay grade. Well, thank you for coming, huh? Thank you, Professor Diva. That was amazing. So we'll move on to the next, and it's the same theme because we could only pay the cardiologist only for one session.
You can afford for one session. Yes.
So we also did another AFib study today. By the way, I just want to, before I introduce my esteemed resident, Dan the Man, I just just want to say that this study was brought up to me by a cardiologist, a friend, who came to me and said, there's no new evidence in AFib, blah, 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 blah. But, it's still preliminary evidence. It's a tiny study. And as a critical care physician looking at the 15,000 patients and call it a tiny study, I'm shocked. I'm just like, what is going on here? I feel, so the next AFib study is presented by Professor Dan DeMann. He also did a great job. He actually is post-call, so he's been around, admitted how many patients? 10 patients yesterday? Yeah, a lot of patients, and transferred 2, and there was disasters all over the place. He did a great job. Nobody died, and the presentation is done. So everything is fine. So thank you for taking that on, Professor. Professor Dan is a ER resident at BI, and next year is going to be like the boss over there or something, right? You're going to be
a fellow.
Administrator or something.
I'll be an administrative fellow.
Administrative fellow, okay. So the boss of the.
What is administrative fellow?
So the boss of the fellows, or the fellow that's learning to be a boss?
I'm the fellow who's going to be told what to do by everybody else.
It's basically another name for who gets the coffee in the morning, right? Administrative
Exactly.
fellow.
Where do I?
Oh, wait, I'll show you.
Yes. No.
I have a link to a video. I don't know if the audio.
Yeah, audio's on.
We'll get that shut as well. So thanks for having me talk about this study. So I'm going to talk about the.
No, but before you start, Dr. Gilbert, do you have any comments on the last study?
It was a very nice presentation. We're never asked as neurologists to weigh in on these decisions on how to treat after afibrillation is diagnosed. And I would think the major factor in the decision is the age of the patient, and because these antiarrhythmic drugs have a lot of side effects. But,
Yeah, that's true.
I would think rate's easy to control, rhythm not as easy to control. You'd have to weigh those risks against the overall advantages. And it didn't look like the risk of stroke was all that much different in each group. So that would be my only. But we would never be asked to weigh in on that decision. Unfortunately for the patient, but AFib remains a major issue in stroke, and we're still surprised how many patients are really not anticoagulated, and other decisions on when you start it, and after they've had a stroke, and there's so many things to consider from my viewpoint. I think the risk of paroxysmal late fibrillation is much higher than we recognize, and most of or cryptogenic strokes are probably related to paroxysmal atrial fibrillation, which remains an untapped area of therapy. But other than that, I would have no comments about that study. It seemed well done, and certainly was well presented. But I think my only contribution would be maybe age is a major factor. We decide to control the rhythm. So there you go.
All right. Well, thank you, Dr. Gilbert. Professor Shah.
All right.
Go for it.
So I'm going to talk about the rescue AF in patients undergoing atrial fibrillation ablation. So this is the rescue AF trial. And the rescue in this stands for restricted contact force reduces esophageal injury. So this was the study. It was done by a team mostly out of a province in China, in the Yunnan province. It was published in 2019. And it's essentially a study about a particular variation to the technique of doing pulmonary vein isolation. And so I think to fully understand what they were doing, you need to understand what pulmonary vein isolation is, which is something I did not understand before doing this. So I do have a link to a video to just kind of go through the technical aspects of this. I appreciate there are also some cardiologists in the room who are very familiar with this. But the idea is essentially, as mentioned, that there are people for whom the pulmonary vein is the focus of atrial fibrillation. And so if you can electrically isolate the pulmonary veins from the rest of the heart, then you are not having that focus traveling to the rest of throughout the heart and causing atrial fibrillation. So I'm going to try to pull up this video and we'll see if it works.
This video provides an overview of circumferential pulmonary vein radiofrequency catheter ablation.
Let's get to the procedure part of this.
A three-dimensional reconstruction of the heart is generated from cardiac computed tomography or magnetic resonance imaging data using electrical anatomical mapping software. Once in the electrophysiology laboratory, vascular access is typically obtained through the femoral vein. The right internal jugular vein is sometimes used as an alternative. A diagnostic multipolar electrode catheter is placed into the patient's coronary sinus to permit pacing and recording of electrical activity in the left atrium. 2 transeptal punctures are performed and sheaths are advanced into the left atrium. A hollow injecting catheter is placed into each of the pulmonary veins, and contrast is injected to outline the size and shapes of the veins. Fluoroscopy is used intermittently throughout the procedure to guide catheter placement, access to the left atrium, and manipulation of the mapping and ablation catheters within the heart. An ablation catheter is introduced and used to tag a series of anatomical reference points on the posterior left atrium and the pulmonary veins proper. These points together create a basic anatomical outline that is then used to register the true anatomical position of the catheter within the three-dimensional reconstruction generated from the patient's CT data. An assistant at the computer workstation integrates this basic outline with the three-dimensional reconstruction, subsequently allowing the operator to navigate inside a virtual shell of the patient's left atrium. Now navigating inside the three-dimensional reconstruction with occasional reference to fluoroscopic images, the operator performs a series of point ablation lesions in circles outside the pulmonary veins. This is primarily done using anatomical references, although the electrogram from the ablation catheter itself is monitored. Point ablation lesions can be applied in any sequence, but typically a large ablation ring is first made around both the left superior pulmonary vein and left inferior pulmonary vein, followed by another large ring around the right superior pulmonary vein and right inferior pulmonary vein. Data points are added onto the three-dimensional reconstruction display as the procedure progresses.
So I think that kind of does the big picture. To X out of this.
One thing that you have to remember, the left atrium here is, just look at it here, as you can see, the whole left atrium, the size of left atrium probably like the size of a walnut. So you can imagine.
Oh, God. Can I ask you, during the procedure, I didn't know that they do this 3D during the procedure, or this is just for demonstration?
No, they do it like this.
Like
So
3D? Wow.
they do the mapping first with the cardiac MR or CT. So
Yeah.
they have a map, as he said,
Mhm.
as they said. Then they go in and they match the map with whatever they are doing. So it is 3D.
Wow.
Yeah, there's a lot of preparation for each of these
Yeah.
patients as far as the imaging modalities that they use. So there are different types of catheters that can be used for this ablation, and because they are directing heat to ablate the area of the heart, there are potentially complications from that. So there's mechanical complications, there's thermal complications from this, and specifically this study was interested in the atrioesophageal fistula, or esophageal injuries, which can be formed as a thermal injury and also a pressure injury, which has a fairly insignificant incidence, but a pretty devastating effect. So they're saying, up to 0.2% incidence, but 16% of the total deaths after ablations come from this. And if it happens, the death rate is like 76%. So they're using a catheter here that has a force sensing mechanism as opposed to a non-force sensing mechanism. The idea is that if you're using less force, you're causing less injury to the tissue and less likely to cause a thermal injury to the esophagus and cause this particular complication. This is a schema showing what they're doing, and they have the pulmonary veins here the rings of ablation around them, and then they're showing how the esophagus is kind of overlying this left atrium and sits right behind it in various anatomical locations. So you can see how it would be fairly easy to poke through that or cause an injury to the esophagus. And these pictures down here, and I have a couple more of them later, are examples of the thermal injuries that occur afterwards. And actually all of the patients in the study got EGDs afterwards to assess for these thermal injuries. So the design here, and as I said, it's a restricted contact force reduces esophageal injury is the name of the study. It's a prospective single-center randomized controlled study performed in November 2015 to September 2016 in Yunnan province, China. They enrolled 89 consecutive patients with a mean age of 57. It was 57% male. And they were symptomatic with drug refractory atrial fibrillation, about 2/3 paroxysmal and 1/3 non-paroxysmal. And they were undergoing a circumferential pulmonary vein isolation procedure. They planned to power the study to have 88 studies, so they just met their goals as far as power. Overall, as far as the PICO for this study, the population was adults with symptomatic drug refractory AF undergoing a CPVI. The intervention was using a contact force sensing catheter during the ablation with contact force limited to less than 20 grams of pressure, and the comparator was a non-contact force sensing catheter. So they weren't actually varying the pressure, they were actually using a catheter that did not sense pressure at all. So we don't know how much pressure they used. And then the outcome was the rate of esophageal injury noted on follow-up EGD, though they also looked at sort of the anatomic variations and some of the mechanisms of injury in their study. So they enrolled initially 97 patients. They excluded 7 of them because 3 of them had an atrial thrombus, and then there was some esophageal disease in a few of them, so they ended up with 90 patients included, and then they randomized 45-40 to the non-force sensing and force sensing groups, and then they excluded 1 over here for a hydropericardium. They all underwent EGD within 24 or 48 hours, and they found 9 esophageal injuries in the non-catheter or non-force sensing group and 0 in the catheter in the force sensing group. So that kind of gets the results a little bit. They did pretty well randomizing their patients. They have a whole bunch of metrics, age, gender, BMI, type of AFib. None of these are statistically significant differences. And then they went a step further and they also looked at the type of sort of anatomy that they had. They classified it as type A, B, or C. I don't know if these are standard definitions, but that's how they went about doing it. And this is essentially how they define the A, B, and C type. So in the A type, the esophagus is lying behind the left-sided pulmonary vein. In the B type, it's kind of in the middle, and in the C type, it's kind of in the right side there. So,
and they know that by CAT scan?
Yeah, they're doing CT beforehand to assess where it is. And they do note as a limitation that there is some, because it's dynamic, that there may be some variation in terms of where things are during the study. So, of note, most people have this type A, at least in this population, the type A esophagus orientation, where it is mostly overlying the left-sided pulmonary veins. So the outcomes that they had here were with restricted catheter force, they had no cases of esophageal injury, and in the non-restricted group, they had 9 cases of esophageal injury. They did not actually perform statistics on this, but I went back and did it, and their chi-square is less than 0.01, so this is a pretty significant difference. None of these were atrioesophageal fistulas. They were just ulcers or minor injuries, kind of like that shown up here on the right. So you can see what an early thermal injury in the esophagus looks like, and then they did a repeat EGD, and then it resolved with time. So their outcomes as far as freedom from atrial tachycardia was pretty similar. So they did follow up out to 31 months, and there was no statistical difference between these groups. Here is the force that they used and the force delivery times that they used. So again, they're targeting under 20 for their force, 20 grams, and then they limited the amount of time at 20 seconds per point that they were ablating. And again, this is this freedom from tachyarrhythmias with a Kaplan-Meier curve that shows pretty similar outcomes. perhaps favoring the force sensing group just a little bit, but not statistically significant. So the conclusion of the study are essentially that using a contact force sensing catheter in this study with contact force restricted to less than 20 grams at the posterior left atrial wall may reduce the incidence of esophageal injury with similar procedure effectiveness. It's a limited study in the sense that it is a single center trial. It is a small sample size. It is non-blinded, and these investigators were almost certainly looking to see an advantage in the force sensing group. And then the other major problem that I see with this is that they're using a different catheter and they're not assessing force. So we don't really know if it's the force that's causing this difference or if it is the attention that the investigators are paying to measuring force, or if there's something intrinsic to the catheter itself. I'd be curious if anyone in the audience knows more about the specific catheter types that are used for this, but my sense is that things are moving towards force sensing as being a good option, but there's some underlying variables that are hard to assess. It's not double-blinded, it's a single-blinded study in that sense. So I have some additional data that we can talk about where they map out the sort of the characteristics of the different injuries and show where they occurred, but I think the main takeaways were the catheter, their force sensing catheter had fewer esophageal injuries, and they show what a normal anatomy for the esophagus looks like with all this.
Beautiful. You want to go over the question?
Oh, sure. I did not include it in the slide. My apologies.
So, a 58-year-old female with history of paroxysmal atrial fibrillation is undergoing circumferential pulmonary vein isolation procedure compared to using a non-force sensing ablation catheter. Using a contact force sensing catheter restricted to less than 20 grams force is likely to have which of the following benefits? Increased incidence of initial success of ablation, decreased duration of ablation procedure, reduced rate of esophageal injury, increased duration of ablation success, and decreased cost of the procedure.
Reduce rate of
Yeah, number C.
Yeah.
So, thank you for the nice presentation, Professor. Very nice. Thank you.
Thank you.
Imagine if you were in 28 hours of post-call. What would it be? But I'm just concerned about one thing. When we have an atrioesophageal fistula, the endoscopy team might ask for cardiology clearance. That could be a problem. But I'm just obviously it's so subspecialized. But I'm thinking something. I don't know. Maybe I'm crazy, but the scope that they use for EGD is different than the scope that we use for bronch, right? There's a movement like this. Like they can literally move it laterally. They have another dial.
Yeah.
Can they do that in this procedure? Like, can somebody do an
Just move it out of
EGD
the
at
way
the same
while
time?
they're-
Pull it out of the way as you're doing the left, and pull it out of the way as you're doing the right.
Yeah.
Could that be something in the future? Maybe, I don't know. I mean, I'm sure somebody thought of it.
Yeah. And my understanding is this is a procedure that pretty much only electrophysiologists are going to be.
There's
doing.
various, not all the electrophysiologists do the atrial ablation.
Okay.
There are some of them they do it. I mean, when you do an EP fellowship, you do some Afib ablation, but not all of the EP they do the Afib ablations. Only a subset of them go there because it's very, very, I would say, boring. It's very difficult thing. I mean, at least for me,
Yeah.
because as you see, all of those things, the ablation. I mean, left atrium is like the size is like a walnut. Imagine all of this catheter, there's 4 things coming into the walnut, and then they're trying to burn around them.
Yeah.
So it usually takes 6-7 hours at least.
Wow.
So you have to be very, very patient. Usually EP studies like this is the worst thing.
Yeah.
So not all the people, not all the
It takes forever. And patient has to be intubated, sometimes paralyzed. Right?
Yeah, because can you imagine sedated for 8 hours on the table?
Or
So
it's like you're doing like this and you move a little bit.
Yeah.
They're done.
Yeah. One thing I want to add to this, so if you I mean see all the mapping and everything, it's a very, very expensive procedure. Obviously, it's very profitable for especially company and industry, because there's like $1 million equipments for using this. Now, having said that, I have no evidence for it, but I always, especially the past couple of years, they are just pushing for ablation. They're putting papers. Ablation is better than medical ablation is better. I always in back of in my mind,
Who's pushing?
if you have a huge industry which is extremely profitable, can you? I mean, you know all of the studies. You could do a little bit of like this. You can get a different day, different results.
Good.
So is it biased, the study that we are getting toward the ablation?
Yeah.
I don't know the answer. Again, I have no evidence for it, but it's always back of my mind. I mean, there is no industry behind amiodarone or dofetilizotol, but there is a huge multi-billion-dollar industry.
I mean, did anybody notice? I mean, you know this probably, but did anybody notice when the Impella became, out in the market and there's a room for it in cardiogenic shock? Suddenly, the study came out that the intra-aortic balloon pump has been used for 30 years or 40 years. Doesn't work. Doesn't affect outcome. And like, come on. Well, there's something to it, And of course, nobody's saying that anybody's falsifying anything, but it's just there's a push, and the push just gives you bias.
Yeah.
Unintentional bias.
I will say this is an impressive amount of resources directed towards doing this study. I mean, it seems, given the amount of pre-imaging that needs to be done for all this, and the amount of time to do each one of these ablations and the follow-up EGDs and all of that, it's enrolling even 90 patients to do this is a lot.
Yeah. So anyway, that's my feeling about the ablation. But still, younger patient, I'm sending them for ablation.
Yeah.
I mean, if they fail.
In the abstract philosophical way of thinking is that, in this 2020, 2030, nobody should be on drugs for AFib, or whatever. It should be like another procedure. It doesn't have to be this one. Just like, we should be able to, technology or devices, new devices that will ablate AFibs, and that'll be the ideal situation.
But remember, on the other hand, remember we were talking about, like 10 years ago, we were stenting everybody who has a little bit of blockage in the coronary arteries, and we've shown one after another that stenting doesn't benefit except for acute coronary syndrome. So that's the other thing. Does ablation for AFib benefit patients? So far, a study says yes, but.
I remember when I went to California, they shut down a cath lab. I was just doing some work over there, and I heard about the other hospital. They shut down its cath lab because they were doing, if you remember, coronary ultrasound.
Yes.
They were doing intracoronary ultrasound, which seems like a great technology, and they were finding plaque everywhere. So they putting stents in everybody. That turned out to be not the right thing to do.
So anyway, again, for ablation, I have no evidence, but it's always back up in my mind.
So, Barbie, any comments on this?
I kind of agree. You always follow the money in the study.
That's exactly correct.
I mean, if you look at Zygris, who funded all of Zygris?
Absolutely.
Yeah.
I'm putting in the
and then what happened?
Surviving Sisters campaign.
And then what happened 10 years later? It got pulled off the market for
That's
really
right.
bad outcomes. But yet they got 20, whatever, significant large volumes of money. Every patient got it.
You guys know the initial recommendation for the fat-free diets in 1960s and 70s?
No.
You don't know the studies? Is there this story?
No.
Okay. Maybe Dr. Gilbert knows it. So in 1960s or 70s, this is documented. I'm not making up. It's in the literature. So in 1960s, they were looking at basically at the health effect of different diets, and they're looking at the fat, they're looking at the sugar, different components. So the sugar industry, which was very powerful, paid a Harvard professor, which is actually the name and everything is there, to publish a study in which fat is the one that's causing all of the cardiac problems. So they don't blame, they basically say don't blame sugar, but blame the fat. And remember, it's 60s, so they can do like more bold things like
Yeah.
this. So at that time, all the recommendation was the fat-free, fat-free, fat-free. So in 70s and 80s and 90s, it's all fat-free, fat-free, fat-free. And when you have a fat-free diet, what you have to replace fat with something to give it a taste. And what you replace fat with? Sugar. So all of these sugar-free, fat-free things, they replace sugar with it. And it's been shown one of the major reasons for the epidemic of the diabetes, obesity after 70s and 80s or 90s is exactly like you said, the fat-free diets, which the industry is sponsored to remove the blame from the sugar. That's in the past 10 years that you're really going back to the sugar as the main thing.
Unbelievable. Unbelievable.
So
thank you everybody for. So we have one last thing in the what is this? 2 minutes left. This is a tradition. We just have to do it because we do it all the time. This is a study that the manuscript. We're still gonna add more names here, but people who participated. This is homegrown. You know homegrown.
Yeah.
This is homegrown here. So this is our Calmeric protocol study. And basically what we've done, this is the abstract, if you want to read it quickly. Basically, we had severe sepsis patients that come to the ICU. So just historically, we have the Calmeric protocol that came out in 2018, which used 3 medications, vitamin C, thiamine, and hydrocortisone for patients with septic shock. In this hospital, we used that protocol and we added 2 more medications to it. Hence, we call it the Calmeric protocol, and it's midodrine and florinef, and we added that to all patients with septic shock. That was in May, I think in May or April 2018 or 17. But then in May 2000, and let me just say May 2000. May 2019. So May 2018 we used it for septic shock. In May 2019 we made a decision to actually roll it in to use it also for severe sepsis. So we're using it now for severe sepsis, like early stuff, and septic shock too. They're innocuous medication, it doesn't do anything really. We discussed here the side effects of each medication. It's not a lot, like hydrocortisone for 2 days doesn't kill anybody. Thiamine for 2 days doesn't kill anybody. High dose vitamin C for 2 days, that's a vitamin. And then you have fludrocortisone for 2 days and midodrine for 2 days. It's very difficult to cause a side effect with these medications just for 2 days when you're in severe sepsis or septic shock. So this study is actually unique in a way that we decided to actually study the effect of those medications on severe sepsis, not on septic shock, because the original study was on septic shock. And the primary outcome was to look at severe sepsis progression to septic shock, what the percentage, and mortality, if possible, and also other things. So this is what we found, just to cut to the chase. We did the baseline characteristics were the same, and then this is our thing. So basically, the control group, we found 115 patients in the control group, and about 108 patients. So this is obviously a retrospective review. This is a control 5 months before, and the treatment group is 5 months after. So the control group, we had 115 patients, 26 of them actually progressed from severe sepsis to septic shock, meaning that they had to go on pressors, the central line, the whole deal. And after the 5 months after, we had only 7 out of the 108 patients progressed from severe sepsis to septic shock. So that's amazing. It's significance here is going to be resources, money, like financial stuff. But also, when we looked at the mortality almost mirrored the exact same thing. 28 out of the 115, and here 11 out of the 115 died, and both of them were statistically significant. So it also reduced mortality in patients who arrived. This was a very difficult study to do, or to collect the data, because we were trying to find the severe sepsis only that come to the ICU, that presented to the ICU with severe sepsis. So when you look at the codes are all over the place because it doesn't matter. So we don't know. We just wanted to do on the day or the time they touched the ICU, they were in severe sepsis. That's the type of patient we wanted to look for. So that was also very statistically significant. And this is also a very interesting finding because we looked at the patients who actually progressed to septic shock. So before progressed to septic shock, they would get the same protocol because, and after, when they progressed to septic shock, they already had been getting the protocol anyway from the beginning, right? So once you progress to septic shock, you're getting the same protocol, and we found 13 deaths out of 26, 2 deaths out of 11, and that was not statistically significant. So that says something about the protocol, that this actually changed outcome. You know, although this is a small number of patients, but it adds, you know, some value, some additional, credence to the protocol, and say, okay, well, people who got it, you know, even though the one before got it a little bit late when they went to septic shock, and these ones got it from the beginning, but still both of them got the same protocol. They had no difference in mortality, although this is much less obviously mortality, but there is, you know, and statistically it wasn't significant. So this is we didn't publish it yet, but it's like 99% ready to be published. Just wanted to let everybody know and see if they have any opinion or additions or.
Cal, for a brief period, you were just doing the math, right?
Yeah.
I have to run,
All right.
sorry.
All right. No, that's good.
Thank
Thank you. Yeah. For a year we've been doing the Marek.
Do we have numbers for that?
We don't, but we can go back. It's just, you know, it's difficult to get data.
Oh,
You know, this one took us 3 years, you know, 2 years. But yeah, we noticed anecdotally that it works, you know, for the Marek only. So that's why we added the 2 other medications, and we noticed that worked too. So then we did the study, and then we collected the data.
How come America?
Cal, is there any way you can send this to me to read?
Yeah.
Whenever?
I'll send it to you. Yeah.
That'd be great.
Today,
Thank you.
yeah.
Is it why, like, how come we're only initiating Merrick in the ICU and not like in the ED before they get admitted to the ICU or the floor
Well,
on the floors?
That's why he's saying send it to me. we have to test it in the ICU first. This was not a study, by the way. It was a change of practice, and we studied it after. We can't study things here. We can't do prospective study. So the change of practice, we noticed some difference. We assigned some nice people to do the data collection. They did, and everybody participated. We got the data. If this gets published, then I'm visiting Professor No and Professor Gopo Nair in his office, Professor No in his office, and talking about it. You know, I'll send it to you, Professor. I'll send it to you today. This is just a pre-publication, so we'll see what the end it's going to be looking like.
Al?
Yeah.
Jeff,
Yes.
I have a question.
Yes, sir.
Is it the speed of the treatment or the treatment itself that makes the difference here? The early recognition and some intervention, or is it mostly the intervention itself? In other words,
That's an excellent point. That is an excellent point. I suspect it's the speed of the treatment, because, you know, severe sepsis, that's when you can make a difference. Once you go to septic shock, it's very difficult to make a difference. We can, but it's just like we're maxed on what we can do for them. But you're right. I mean, applying the same thing that, according to Dr. Merrick and his study, works for septic shock patients. Why don't we apply it for severe sepsis patients? Because that's where the difference can be made. So yeah, I suspect the speed of the treatment. Of course, the last graph that I showed, it showed that, you know, the people who received the treatment on both sides because they progressed to septic shock had no difference. But I suspect the no difference is because of the small number of patients, not because not because whether you receive the treatment is the same. I think just applying those things early makes difference, I think. Bobby? Okay. Anybody else? All right, well, thank you very much. That was an excellent journal club.
Thank you.
Yeah, thank you. Bye, Dr. Gilbert.